Right. So my interest is really in lots of things related to ear and hearing care, but I'm going to talk to you particularly about the chronically discharging ear. So what are we talking about here? What we're talking about here is what's often called a hidden disability. So this is a hole in the eardrum. This is a view of the down the ear canal, and that is a view, an endoscopic view of an eardrum. And there's a little hole there. This one's actually dry. What this problem causes is that many people affected by this will have discharging ear. So once you've got a hole in the eardrum, you can have pus coming out of the ear intermittently, maybe sometimes every few years, sometimes frequently, sometimes continuously. It can also be associated with hearing loss. So certainly if the hole is large or it's associated with persistent inflammation, you can damage the bones of hearing, and all of this is hidden deep inside an ear canal. So it's often called a hidden disability, and I'm going to try and tell you that this is actually a very, very common problem and under-recognized, affecting people in the most impoverished areas. So we can actually look back through history, and Sir Charles Ballance, who's a well-recognized ear specialist in my specialty, I'm an ear surgeon. They reported that chronic suppurations existed in such quantities. There were thousands in the hospitals of London at that time. We don't see that anymore, but I think we should not forget that this is historically what used to happen in the UK. And actually, if you look at autopsy reports from 19th century England, they showed, I've looked through them, 1 in 200 people died from ear disease. So not only is it a disease that leads to a hole in the eardrum, but actually that persistent inflammation can, in some rare cases, lead to the inflammation spreading up, going through the bone above the ear and into the brain, causing meningitis or a brain abscess. And we still see that now in low resource settings. I still hear of people, oh yes, a few people have died last month from the ear disease going up into their brain. We've actually just published last week our epidemiology review of this disorder, and there's still a limited number of studies, but we looked at 20 or so studies over the last 30 or so studies over the last 20 years. And we use that to model the global prevalence of disease using some variants. And what we found is we think there's an estimated nearly 300 million people living globally with this problem. So it is a huge disorder, massively under-recognized because it's hidden, and it associates with poverty. So wherever we find poverty, socioeconomic deprivation, we find this disease prevalent. Every single community where I've been with impoverished, we find this disease. 85% of the disease burden seems to be in lower middle income countries. I see this in the UK, but it's relatively rare. Maybe 1 in 200 people in lower middle income countries, typically 3 or 4% of the population. In some areas, much, much higher than that. So a quarter will have bilateral disease. 2/3 of them will have disabling hearing loss. That means a hearing loss that interferes with their ability to interact in life. And that includes, obviously, it includes children as well as adults. And that can include inability for education, inability to gain employment, and a stigma associated with people thinking, hey, this person cannot hear, they must lack intelligence. So the consequences are quite severe. Um, the ear discharge is also associated with a lot of stigma. It's not really something that's been looked at that we are looking at now. People hate having a discharging ear, especially young girls who find that it's difficult for people to get intimate with them because that smelly ear makes people not want to go near them. So we know there's lower quality of life, there's self-stigma, and there's stigma from society. And although I give you some statistics, I always say, look, let's not forget that these are human stories. So these are some of the stories we have from locations such as Cambodia and Bangladesh, where I work. And she says, look, she doesn't want anybody to know her problem. She wants to keep it secret because of that self-stigma. And people feel unable to manage this disease because actually the problem is these people living in these low resource settings often have no access to care. There is nobody that seems able to help with this disease. And we've done some surveys of people have sought often lots of traditional healers and unfortunately had no real success. So the gold standard for managing this disorder is once the hole in the eardrum is established, and if it's causing repeated infection, we think it's very unlikely to heal by itself. The gold standard is actually a surgical repair to repair the eardrum. And if we repair the eardrum, which works 80 to 90% of the time, they end up with a dry ear and sometimes with a hearing ear. So no more discharge and very good quality of life outcomes from that surgery. The problem is there are very few ear, nose, and throat specialists. And so here's a recent systematic review that we undertook showing the numbers of specialists, and it's very, very low. You're talking in some countries, such as Malawi, there are perhaps two ear surgeons for the entire country. In Zambia, there's maybe three who can specialize in ear surgery. In places like South Sudan, there's nobody. So we are not going to be able to easily solve this solution with having lots and lots of surgeons in hospitals with people coming to see them. That's simply unrealistic. So some of the work what I've been doing is actually trying to see, is there an approach where we can try to get more involved in the communities? In fact, the communities are exactly where these problems are, because not only is it poverty within a country that causes the problem, but actually it's often in the most remote areas that you see even more disease. Some work I've done is with the Rohingya in Bangladesh. You may be aware of the genocide that has faced the Rohingya minority. They're actually a group from Myanmar in a state called Rakhine State in Myanmar, where they have faced persecution as an ethnic minority, a Muslim minority, in fact. And because of military unrest, they have been forced out of their country, and where they have fled persecution and crossed the border into Bangladesh. So it can only be described as a genocide, where people have been have their homes burnt down, violence conducted against children, including killing of children, killing of men, killing of women, rape, the usual things, unfortunately, that we see in violent genocide. They've gone over the border and they now live in the largest refugee camp in the world, in Kutupalong, where there is 1.2 million people estimated to be living in this camp. They are stateless because they are not actually allowed to enter Bangladesh. They are often described as the most persecuted minority in the world. We were told that they have a lot of ear disease, and so we went into this camp in Kutupalong at the request of the UNHCR to see what we could do to help. And this was an example we could use of how to deliver care to a very remote and difficult to reach population. What I've been trying to do is one of many things, but this is one idea we've had, which is the idea of, can you actually bring surgery to a remote area? Uh, the UN had built a specialized hospital there in a place called Ukia, and we were asked to help. And in essence, we tried a new technique. It's been tried before, but never been tried on such a low scale, which is to try and repair an eardrum under local anesthetic and using an endoscope, so a little camera that allows us to look into the ear without a huge amount of equipment. The idea is then you can actually take a specialist surgeon to a remote area and deliver the care there. So this is how we set up. We actually set it up in a hospital, but the idea is actually you could set this up anywhere. You could set this up in a field camp. You could even set this up in someone's home with the right equipment that you're able to mobilize. So in this case, we did use medical grade endoscopes that already exist from major commercial suppliers, but with what's called a telepack, which is a sort of screen that you can carry around. It was challenging because the disease is very severe in a lot of these low resource settings. So these are pictures you may not appreciate, but the top left shows a very large hole. Basically, the entire eardrum is missing. At the right, this is an actively discharging ear full of pus. Ideally, we would like to get it clean before we operate, but we don't have that luxury on a short trip. And the bottom left is actually an eardrum where there's a big hole and there's also incredible scarring. That's quite difficult to deal with under a local anesthetic, but the patients really wanted us there because they said this ear is such a big problem for me. What we found, it was a small scale study. We only operated on around 25 patients over 2 days. And what we found is that we had a 50% success rate. Now, to be honest, we were quite happy with that. We normally report 80 to 90% success, but under a local anesthetic with those severe scarred eardrums, that's quite good, I think. We are still disappointed. We would like much higher than that, but we've actually got a queue of patients who are wanting to have this operation because so many of them are so troubled by their ear. What we need is now to develop onto the next stage. And what I would really like is not to use traditional medical equipment because it is frankly expensive. That equipment was donated to us, but if we were to buy it, it would cost thousands of pounds. And I've been fortunate now to link up with an engineer in India who has developed an endoscope. In fact, I've got it here on my desk. You're the first people to see this. It's a prototype. So this allows me to look inside an ear and connect it by simple USB to a laptop. Very low cost. It's going to cost a few £100, very high quality. If we can do this, we can deliver this to the masses. We don't need to buy supposed high-grade medical equipment. This is high-grade medical equipment produced at low cost. So we're planning some further trials, possibly actually working in villages in Malawi towards the end of this year. And there's lots of interest in this opportunity. But I'm not naive that surgery is going to still reach everybody. So we've done some sampling in Kutupalong, and what we found is that actually from a random household survey, 15% of them have a hole in their eardrum, and half of them that's in both ears, and that includes children. So in a camp of let's say 1 million, we're over 140,000 will have a perforation. This is not the ultimate solution. And I think what we also need to consider is non-surgical management. Is there another mechanism to manage the disease? I don't think we're going to cure the disease necessarily without surgery, but maybe we can try and manage the two cardinal symptoms of a hole in the eardrum, which is the discharge from the ear and the hearing loss. And what we want is a non-medical model because we're not going to get enough medical people out there and we would look like self-management. So what we've now just received some funding for some trials that will start this year is to look at community-based solutions to manage the disease. So what we know about otorrhea, that's ear discharge, is that topical antibiotics are not readily available in many of these low-resource settings. Surprisingly, there is not a pharmacy out in the village in rural Malawi. But also you need a prescription and availability is low, but cost is also high. And actually the quality is another issue. Some of the medications are faked. So these is not a solution, but iodine is widely available and could be self-administered. So what we're interested in is can you wash your discharging ear with iodine and can that allow this to settle down so that in effect the disease is self-managed. You don't need medical intervention. When your ear discharges, you wash it with iodine. The hearing loss. The hearing loss is predominantly due to what's called a conductive hearing loss. It means that the sound can't get to the deeper parts of the ear, something called the cochlea, which is the deepest part of the ear, fluid filled, where the sound's actually detected. The sound can't get there because either there's a hole in the eardrum or there is a damage to the bones of hearing. So a traditional hearing aid, an air conduction hearing aid that you put inside your ear, is actually not widely available to populations in low and middle income countries. Frankly, that is because all of the hearing aid companies are in cahoots. They're not interested in selling to this because they sell them at ridiculous prices of up to $6,000 to rich Americans who will pay for these tiny little medical devices that are no more complex than a mobile phone. There's a need for an audiologist to program them. There's a need for batteries, and actually they can make the discharge worse if you've got a hole in your eardrum. So what we're interested in is an alternative hearing aid through bone conduction. What that is a mechanism to vibrate the skull, bypass the diseased ear, and send the sound directly to the inner ear. Well rehearsed, a mechanism in high resource countries, but the problem is that the traditional aids have been very expensive. So evidence for treatment of ear discharge. I was actually involved and still am in a suite of 7 Cochrane reviews to look at medical management of ear discharge. And we found there were very limited studies. We know the topical antibiotics probably are the best treatment, but for antiseptics, there was only one trial. So is this idea of using iodine any good, or is it substandard? And that's what we've got a randomized control trial starting this year in village communities in Zambia and Malawi of self-administered topical iodine. And we hope that that will lead to positive results, and that could then change, hopefully, World Health Organization policy on this and mechanisms to self-manage. And then for the low-cost bone conduction, we have found some evidence already. We've just published some papers actually showing that there's clear evidence of benefit for children with other types of middle ear disease. And what we want is to repurpose these for this chronically discharging ear. So again, we've done some pilot studies now in Malawi and in Bangladesh, and we're now this year we'll be starting a large-scale trial in village communities in Malawi and Zambia with actually a student from Zimbabwe that will be leading those trials. We have had so far very positive outputs, but watch this space. This is a slide I often show. This was actually one of these devices that was left in Malawi many years ago. But unfortunately, this thing called a pandemic hit. So it's very difficult to follow up what happened with this child until after the pandemic. And then when we revisited after the pandemic, this is what we found. This is this child's most treasured possession. She takes it, she charges it, she looks after it. It has obviously had some injuries, but it's been fixed and repaired. The teachers say this is the best thing they've ever seen. The child is completely transformed, is doing well in school. So we may not be able to fix all the holes in the eardrums, but I hope that we can stop the discharge, and I hope that we can give children and adults some of their hearing back so they can participate and maximize their potential. I'll stop there. Thank you.